Everyone, good morning. Today we're joined by Dr. Eddie Stenehjem to give our weekly COVID-19 update around the state of Utah. As always, we're going to start with case counts and go over what's been happening since the last time we spoke. The numbers I will be reading were reported for yesterday, just so everyone is aware. But yesterday's daily case counts was 1,113, which is up 298 since last Thursday. We had a total of 3 deaths in the state of Utah, and our hospitalizations are at 353. Our 7-day rolling average percentage for testing is 14.7%. We've had no new breakthrough deaths, and since mid-January, 98.5% of the 667 deaths that have been reported have been unvaccinated. Of the 4,839 cases in the past week, 87% of those were also unvaccinated. Yesterday, Utah reported more than 1,100 new cases of COVID, which is the highest one-day number since last February. Let's talk about that first. Dr. Stenehjem, how concerned are you about our current surge that is happening?
Yeah, I'm real concerned. It's when you look back the past month and a half, you're just seeing this linear line going up with more and more cases. And, then you offset that by a couple of weeks and that same line has occurred in terms of hospitalizations. And now, we're at a point where our hospitals are again full. We're over that 85% capacity benchmark that we've set. And we know that when you get to be running a hospital at 90% capacity, things aren't as efficient. You don't have ICU rooms readily available for those trauma patients or whatever it might be. And so, if we continue on this trend, we're going to be back in that same position we were in December and January, where we've got a big issue from a capacity standpoint in terms of taking care of our patients, which then leads to downstream impacts of we need more clinicians, we need more nurses, we need all those things to be able to care for those patients, which then trickles down to, what are we not doing for our communities and for our patients? And so it's certainly a disturbing trend of kind of the direction that we're headed. And we hope that we can kind of change course, especially as we're thinking about school going back in session here in the next, I can't believe it, in another month or so.
And there's also been reports too around COVID cases and deaths increasing throughout the entire United States, especially in those states that are lower rates of vaccination. It's been reported that in the past week, there are twice as high case counts and deaths in states that are vaccinated with that less than 50% on average. What does that tell us? And also, should we be concerned in Utah? I think we're sitting at like 48% total, not just eligible, but total for the population.
Yeah, I reviewed these data on Monday, and when you look at the cases per 100,000, Utah was ranked number 11 out of the 50 states in the U.S. And then if you look at the states that have the highest number of cases per 100,000, and then you look at their vaccination rates, those are the states with the lowest vaccine rates. And so it was Louisiana and Missouri and Arkansas. There's a lot in the southeast there that had pretty low vaccination rates in the 30%. And so there's a direct correlation between cases per 100,000 and vaccine coverage, and indirect correlation, meaning that the lower the vaccine rate, the higher the number of cases. This just comes down to the fact that vaccines work. Vaccines prevent cases, they prevent hospitalizations, they prevent deaths. And this isn't rocket science. This is what we'd expect in terms of the epidemiology of the virus across the US, that the lower the vaccine rate, the higher number of cases you can have.
Let's talk a little bit more about vaccines too. Pfizer this week, there was reports coming out that they were saying a third dose of its vaccine could strongly boost protection against the Delta variant. They said that potentially it could have a 5 times higher effect for those 18 to 55 and an 11 times higher effect for those 65 to 85. Let's talk about that a little bit and then get into specifics around the vaccines and what we've learned since the clinical trials have started as well.
Yeah, so there's a lot to unpack there. And Pfizer had an earnings report. It's interesting now we're getting scientific data through an earnings report. Prior it was we'd get it on these preprint servers before it was peer reviewed. Now we're getting data from an earnings report, and then I'll go to preprint, and then I'll go to peer review. So, we have to kind of take this all with a grain of salt. So I think we should talk about waning vaccine immunity and then the need for a booster. Okay, so I think that's probably the sequence that would be best in terms of clarity of this. Pfizer just reported yesterday on a preprint, so non-peer reviewed paper, but a manuscript that is on the servers. They looked at their 6-month vaccine efficacy in their original trial. So they had those 40,000 patients that were randomized either to placebo or to vaccine, and they're following them for 2 years. And we had data up through 4 months. That was kind of the last endpoint. Now we have data up through 6 months, which was released yesterday. And what they report in that, they report a lot of different numbers, but when you dig into the details, I think the important thing that is getting picked up by media is that the vaccine efficacy in the 0 to 2 month range after the second dose, so 2 months after the second dose, was 96%. And that's what got them FDA emergency use authorization. That's incredible. And we move forward. Then when you look at 2 to 4 month, the vaccine efficacy is now reported at 90%. And we already knew that. That was data we talked about and we said, this is great, it looks at 90%. Now they're reporting their 4 to 6 month data, which shows that the vaccine efficacy is 83%. Okay, and so what they're seeing in their very well done clinical trial where everything is very structured and these patients are followed very, very carefully, is that the vaccine efficacy has gone from 96% to 90% to 83%. So there's this downward trend in vaccine efficacy in terms of preventing symptomatic illness, regardless if it's mild, moderate, or severe. And because of that trend, they have been investigating booster shots. And so this is essentially a third dose of the same vaccine, not a changed vaccine, but the same vaccine that they used for the first 2 doses. And they've been investigating how well that boosts your immunity. And so not looking at the effectiveness or the efficacy, but just how well does it boost antibody levels. And what they've seen is that when you give a third shot, you are increasing those antibody levels very significantly, 5, 10, 15%, or 5 times what they were after the second dose. And so what they're showing is that the vaccine efficacy is waning with time, and that if you give a third dose, you increase antibody levels, which most likely is going to mean that you're going to have increased vaccine efficacy after that third dose. And these are data that they're taking to the FDA and the European FDA to try to get approval for a third dose, even before the FDA grants, full BLA, getting the full accreditation of the FDA for the vaccine. So that's where we're at in terms of what Pfizer's doing and what they've reported recently in their earnings report.
What about Johnson & Johnson? Do we have any data around that specific vaccine for the Delta variant and what we've been learning?
We've got, when you look at the total number of people who are receiving the J&J vaccine, it's really pales in comparison to that of Pfizer and Moderna, so it's a really small percentage. And so we don't have really solid data on how well J&J does against Delta. There's some small reports that says it does relatively well in terms of preventing severe illness, but not nearly the robust data that we have with Pfizer, which is the predominant vaccine used not only here, but also in Israel and the UK. And so most of the data in terms of waning immunity and then effectiveness against Delta is coming from the Pfizer shot.
Do you have any thoughts around what can be done to increase vaccination uptake, especially here in Utah? I know that there are a few places, like federal employees for California and a couple things, or state employees, I should say, that are mandating stuff, which Utah is not at. We're not there yet. But do you have any suggestions on what maybe we can do as a community to get people to be more involved and want to get vaccinated.
Yeah, you're right. We've really kind of stalled out in terms of the number of people vaccinated. And the question is, how do we pick up this remaining 30 to 40%, depending on the community you look at, that's currently eligible for the vaccine? We've vaccinated the people that have been eagerly waiting this vaccine. We vaccinated those people and we got them done quickly, and it was an impressive effort put on by the state. The remaining people is going to be much harder. And these are now discussions that need to be had with primary care clinicians, physicians, advanced practice practitioners, nurses, nurse practitioners. These are the discussions that we need to have in those exam rooms. And it's not going to be a one-time thing. It's not going to be, oh, because they talk to me, they're going to get their vaccine. This is going to be something that's going to have to be a repeated conversation for those people that we need to take on with respect and caring. And I think it's also important for us to, share personal stories of why it's important to us that our community members get vaccinated. And I think it's going to take everybody, being respectful and talking about this in a respectful manner to get people to change their behavior. And there's going to be some people we're just not going to vaccinate. That's fine. We understand that. But we want people to know that this vaccine saves lives, that it prevents hospitalizations, and that it's safe. And I think those conversations need to be had throughout all of our community, including in churches and in doctors' offices and nurses, wherever it might be. We all have a responsibility to talk to the science of this and why it's important.
Along those same lines too, I would love to know what precautions you feel like people should be taking now as well, vaccinated versus unvaccinated, and just like personal precautions people can be taking as the Delta variant kind of circulates in the community.
Yeah, so CDC came out this week that said that regardless of your vaccination status, vaccinated or unvaccinated, if you are in a place that has high transmission, that you should wear a mask indoors, especially in places where you can't socially distance, around people that you don't know their vaccine status, et cetera. So essentially everybody should be wearing a mask indoors. Because this Delta variant is so transmissible, and because if somebody who is vaccinated gets infected with the Delta virus, the Delta variant, they can transmit the infection just as well as an unvaccinated person. Okay, so if you are vaccinated and get infected with Delta, you can transmit that virus effectively. And because of that, I wear a mask indoors. And so if I go into the grocery store, if I go wherever I go indoors in public places, I wear a mask. I'm fully vaccinated. I got fully vaccinated in December, or I was fully vaccinated in January. So I'm now at that 6-month part. So there's a potential that my effectiveness of that vaccine is waning for me. And because of that, and because that this Delta virus is so transmissible, me and my family have chosen to wear masks when we go into grocery stores and public places. The way we interact with, our social network and our families is that we, make sure that people are vaccinated. If they're not vaccinated, we socialize outside, and we don't have big, large gatherings. And so we're still pretty cognizant of it. And if anybody has symptoms of an upper respiratory tract infection, sore throat, runny nose, colds, anything like that, we make sure that people are tested. And we have at home tests, so those Binax Now tests that you can get at any drugstore. We have those at our house, and they take 15 minutes. They're pretty good. And if anybody has a symptom, we swab them. So that's what we're doing as a family, and staying safe.
A comment we just received on Facebook around the vaccine is someone wants to talk around vaccine and potential deaths that have been related to them, and talk about the risk between contracting COVID and the risk people think that exists with the vaccine. Can you just talk about that, please?
Yeah, so, I'm here at Intermountain Medical Center. I'm on call for the hospital. I haven't seen or heard of a vaccine-related death within our system. I've seen hundreds of deaths due to COVID-19. And so, you know, I just haven't seen a vaccine related death, just period. We have seen rare complications from the vaccine that have been reported in terms of the pericarditis and myocarditis. We have seen that. Those people have been admitted to the hospital and have been treated and been discharged. We haven't had any deaths from that. And so this perception that this vaccine causes death is not one that us in the medical field have seen. We have seen lots of deaths due to COVID-19. And so when you're trying to stack up, risks, so what is the risk of this vaccine? So there are some risks, right? There's the risk of, feeling poorly for 24 to 72 hours after the vaccine, particularly that second shot. There's definitely a risk for that. It's a transient period can feel pretty poorly for a little bit. That's a risk. The risk for myocarditis, pericarditis, yep, it's there. That signal is there. We've seen that in the reporting system, but it's incredibly low. And then the J&J vaccine has the risk of clotting, which we don't use the J&J vaccine all that much. And so it's a very low risk in terms of our communities. If you stack up those risks versus the risk of getting infected with COVID-19, and the fact that 10% of people that get infected with COVID-19 have long-lasting symptoms, this long COVID, the risk of getting COVID-19 and the real risk of hospitalization and deaths, the risk of missing work for 10 days, the risk of transmitting to family, those are risks that we know and we've quantified and are much, much higher than the risk of a potential adverse event from the vaccine.
I think it's important to note too, you mentioned this earlier, if you're having questions around that, and this specific person mentioned they're high risk, I think it's great to go talk to your doctor about maybe what your specific concerns are, why you'd rather get COVID versus the vaccine, and just kind of compare and contrast the two. It is a personal decision, like you mentioned before, but that conversation with your doctor, I think, is critical to talk about.
Yeah,
that.
And I do think it should be emphasized that we've never had a more scrutinized vaccine. The amount of science and the amount of studies, whether it be on safety and efficacy against these vaccines, these mRNA vaccines, Pfizer, Moderna, that just is an incredible amount of data compared to, the amount that went into other vaccines, including influenza and the like. So these vaccines are incredibly scrutinized. Yes, they're new, they are new, but the amount of data on safety and efficacy that we've had on these vaccines is incredible because everybody's focused on it. And so, I hear people say, oh, these are new vaccines, they haven't been studied. I would push back on that and say, I can't think of a vaccine that's been more heavily scrutinized than this vaccine. And so I do feel that we know the safety profile of this vaccine. Adverse events due to vaccines occur within the first 2 months. That's when the safety signals occur. So that's when we see, Guillain-Barré, that's when we'd see myocarditis, that's when we'd see these safety events. And we now have, over 7 months, 8 months of vaccine administration. So we know what that safety profile looks like, and millions upon millions of people have received this vaccine. And so we're able to actually see these really small signals in safety. And I think the community has done a great job in identifying them. These really small signals for clotting and myocarditis, pericarditis, and the like. I think that's an incredible demonstration that this system works. But we know now the safety profile of this. And so we can say and stand behind these vaccines saying, yeah, these are safe.
A question around flu, influenza, and everything. Last year, we talked a lot about this and how there was basically no cases reported of flu or anything similar to that. It seems like that's still the case right now. Is there a potential that the flu could come back this fall and there could be the two viruses together? How is that really going to work, especially for a potential surge in hospitalizations?
Yeah, it's, keep in mind, last fall and into winter, we were all wearing masks. We were all social distancing. We were really limiting our social contacts. And because of that, we didn't see RSV. We didn't see influenza. We didn't see any other upper respiratory viruses besides COVID-19. And now when, we're no longer masking, we're no longer, doing social distancing, we're already seeing cases of RSV. We're already seeing cases of standard upper respiratory tract infections, seasonal coronaviruses. Those are viruses that we are going to see more of as we move into the fall. Absolutely going to do that, especially if people, we don't go back to masking and social distancing. So as long as masks are off and we're commingling, we're going to see other respiratory viruses. It's going to make the diagnostics pretty challenging this fall, because if somebody comes in with a cold, that could be COVID-19. That could also be human metapneumovirus. That could also be rhinovirus. And that could be influenza if they have the right signs and symptoms. And so it's going to come down to, we're going to really need to ramp up our diagnostics and really be able to identify, is this flu? Is this RSV? Is this COVID-19? Is this something else? To be able to effectively prevent transmission.
I want to talk about that testing piece a little bit more too. Is Utah testing for the specific variants at all? Like, is there a way for the PCR test to kind of distinguish which variant the person specifically has?
Yeah, so the testing for variants is predominantly done at the Utah Department of Health, and they have a strategy where they select different isolates and be able to genetically sequence them. So be able to identify a variant, you have to genetically sequence the virus to be able to say, okay, this is Delta, this is Alpha, this is Beta, whatever it might be. So the Utah Department of Health is doing that, and they report out their sequencing data on their website. And what you can see is that we're 90% plus Delta. And so right now, the importance of sequencing is pretty minimal. If you're infected, you most likely have the Delta variant, just because 90% of Utah is being infected by that. So can we sequence and find out? Yep, certainly we can do that. Utah Department of Health does that quite well in their laboratory. That being said, clinically, it doesn't matter. We still treat these infections the same way. And the vast majority of infections here in Utah are Delta, which is similar to other communities in the Mountain West and Midwest where the predominant strain is Delta.
Is there any concern too that as the virus spreads, there could potentially be a variant that becomes the vaccine becomes completely ineffective towards?
Yeah, so I think you have to realize the more a vaccine, the more a virus is transmitted, the more replication we have in a community. So if we have more and more people infected, we have more and more viral transmission, we have more and more viral replication. Those are opportunities to develop mutations. And those mutations could be detrimental in terms of even worse transmission. It could lead to increased severity of disease. It could also lead to kind of vaccine escape mutants, meaning that that vaccine is no longer effective against that variant. And so we've seen this occur across the globe, right? We saw this incredible uptake of infections in India, and out of India came the Delta variant because of this transmission. We've seen this in South America with the Lambda, variant. And so, what we can say is that the more transmission that we have in a community, the more likely we're going to see a mutant come out of that potentially has detrimental effects.
There's been a lot of talks too around different states or employers offering $100 or some sort of incentive for people to get vaccinated. In your opinion, do you feel like that could help the state of Utah at all?
Yeah, so you've got incentives for vaccinations, you have mandates, so it's kind of the carrot versus the stick, and then you've got the traditional method of communication, education, et cetera. What you can say is you can look back on influenza, and there's multiple corporations and healthcare institutions that have either put in incentives or have put in mandates, and all of those work to increase vaccination rates. And we've seen that happen across the U.S. The VA hospital network now requires their clinicians, their frontline facing clinicians, to all be vaccinated. That went into effect on Wednesday. And those are strategies that work. they increased the number of people vaccinated in a group, and they certainly have been shown to be effective. And then we've also seen areas that have put in incentives, and that has driven vaccinations up as well. And so those are tools that certainly can be used by private organizations, companies, healthcare networks, et cetera, to drive vaccination.
I want to talk about school. You mentioned this a little bit earlier, but school starts in Utah anywhere from 2 weeks from now to a month from now. What is your advice for parents who are sending their children to school who are under the age of 12, who cannot receive the vaccine yet?
I mean, I think we have to realize that this is a different virus than we were dealing with, last fall or last winter even. The Delta variant is so much more transmissible. We've now got a report from the CDC that it's most likely transmissible to a level like chickenpox is, which is an incredibly transmissible virus. If we have children that are unvaccinated, not previously infected, coming into a classroom with other susceptible children, and we've got a very, very transmissible virus, you're going to see this virus transmit in schools. And then those children are going to take the virus back to their homes and transmit to susceptible parents and susceptible grandparents. That's just the fact. We know that if you put 30 people into an enclosed room, that you're going to get transmission. And this is a different virus than we were dealing before. So, those measures of, spacing the desks 3 feet, increasing air circulation, good focus on hand hygiene, by themselves, I'm skeptical that they're going to work. And so what we know is that we know that masking works. And I would say, if I had a school-age child, I don't. I've got young kids that I'd make sure that they're going back to school masked.
Question for you really quick around masking and those who are vaccinated. Do we have any data on the combined efficiency of wearing a mask plus being vaccinated? Is there any reports around that yet?
We don't have any data on that, but we know that if you're vaccinated and you mask, you're going to decrease the chance that you're going to get infected with the Delta variant. That's pretty clear.
Okay, so any last remarks you'd like to make before we take off for the day? Anything you want to let people know?
I just think it's, I'm a infectious disease physician. I've been doing this now for 10 years, and this is such a rapidly changing environment. And that what people are seeing is, science in action, right? We're identifying new variants. We're identifying vaccines that work. We're looking at, optimizing our vaccines in terms of giving booster shots. And what does that mean from an antibody level? For me personally, it's hard for me to keep up with the literature, and this is my job. And so I think the thing that we need to emphasize to the public is the fact that we're seeing rapidly evolving science right in front of our eyes. And it's incredible and it's fast paced. And it's because of that you see things change, whether it be at the CDC level or at the state level, in terms of mask mandates, in terms of going back to school. And you're seeing scientists do the best they can do to keep up with the science. And then we're seeing our public health sector and our private sector respond to those changes. And so, when we see changes in guidance from the CDC, it's because the science has changed. Delta variant is much different than the original, and we have to adapt to that change in science with, changing procedures in public health. And so it can be frustrating to have to kind of go back and forth, but it's because we're following the science and we're following what we feel is going to be the safest for our communities and for our patients and for our families. And so I recognize that this is really hard for the general public. And I can tell you that we're doing the best we can to stay up with the science and make recommendations that are going to keep our patients safe. But it's a rapidly evolving time, and I guarantee you there's going to be more changes. Absolutely. We're going to have to just know that and be okay with that. And, and we'll continue to make the best recommendations we can to keep everybody safe.
Well, thank you so much for joining us, Dr. Stenehjem. I really appreciate it. And if anyone is watching is interested in learning more about the COVID vaccine or where to get one, you can go to intermountainhealthcare.org/COVID vaccine. There's a lot of great resources on there, articles, as well as links to state resources for getting the vaccine. Thanks again. And